All right, I think we'll go ahead and get started. So thank you for joining our second webinar in the Tiny Webinar series. Today's topic is the unexpectedly complex predicament of fluid management in infants born less than or equal to 23 weeks gestation. My name is Noelle Young. I'm a neonatologist at Duke University in the US, and I'll be helping to moderate today's session. We have two excellent speakers today. I will hear from Dr. Jeff Segar, who's a professor of pediatrics and physiology at the Medical College of Wisconsin in the US. And we'll also hear from Professor Johan Agren, who is the director of neonatal intensive care at the University Children's Hospital in Uppsala, Sweden. Our moderators for today's session are Dr. Edward Bell from the University of Iowa in the US, Dr. Satoshi Kusuda from Kyorin University in Japan, and Dr. Navasimiyam Ambalavanan from the University of Alabama in the US. Here is our lineup for upcoming webinars in this series. After today's session, our next webinar will be held on September 5th and will focus on hemodynamic assessment. So please look out for information on how to register for that and future webinars. Just a couple of quick housekeeping items. The webinar today will be recorded and will be posted later to the Tiny Baby Collaborative website. We encourage multidisciplinary attendance, including we welcome children and families of premature infants to these webinars. Thanks to everyone who submitted questions ahead of time in the registration form. You can also use the chat to send questions, and we hope to have time to address many of the questions at the end of the session. In the registration form, we included a couple of survey questions, so I just wanted to briefly share the results of those now. So first, we asked, in your typical practice, what the total fluid volume that you prescribe on the first postnatal day for infants born at 22 weeks of gestation. And you can see that there was a lot of variation in the responses, but the most common answers were between 80 and 120 milliliters per kilogram per day. And then second, we asked what % weight loss you expect to see in the first postnatal week for infants born at or before 23 weeks gestation. And for this answer question, most of the answers were for 6 to 10% weight loss, followed by 11 to 15% weight loss. All right, so with that, I will hand it over for our first presentation.
What is everybody seeing?
We see your full screen. There we see your slides.
Okay. I apologize. So as Nicole said, I want to thank the organizers for the opportunity to speak on this topic. As Nicole said, we have two speakers, so I'm going to give some introductory part, and then Johan's gonna take us home, and then we'll have time for some questions. So here's briefly the objectives that I'm hopefully gonna cover in about the next 15 minutes. A brief description of body water physiology, a couple slides on renal function and the high risk of AKI, because that's obviously important when we're talking about fluid and electrolyte management in this population. And then we'll talk briefly about water intake as well as sodium metabolism. So just a few key points about the immature kidney function when we're thinking about these infants who are at 22 to 23 weeks gestation is recognizing is that, you know, these kidneys are seeing a relatively small amount of blood relative to those kidneys in adults. In that at birth, only about 5% of the cardiac output is going to the kidneys, whereas in you and me, about 25% is going to. Kidneys have a limited capacity to concentrate the urine, although they can produce a relatively dilute urine. There's some high obligate urine sodium losses that we'll talk about later. Importantly, is there's this high risk for the kidney injury, and the fact that we're dealing with kidneys that probably have about 20 to 30% of their total nephron endowment that they would otherwise have if these infants had made it to term. And it's still unclear yet about what happens with nephrogenesis with infants who are born at this gestational age and when nephrogenesis actually terminates, although it's fairly well accepted now is that ultimately the total nephron endowment is probably less than infants who are born at term, and that in and of itself places these infants at higher risk, particularly for chronic kidney injury later in life. And then evidence from the AWAKEN study, which was a retrospective study that involved multiple NICUs around the country, is Jennifer Jatan published several years ago, that about half of infants between 22 to 29 weeks gestation experience acute kidney injury in the first week of life, at least going by currently accepted definitions of acute kidney injury, which in and of itself is an hour-long discussion. So everyone's probably familiar with this figure from Fritz Hansen that looks at body water, changes in body water, total body water and body water compartments over life. And what we're really interested in talking about is what's happening in the first few days to first few weeks after life. And we have some data on this. So this is a study from Stan Schaefer, again, small study, only 14 infants who looked at total body water and extracellular water within the first day of life, and then repeated these measurements between 3 and 6 days of life. And really what they documented, and as you can see over on the right, is that the weight loss in this population of infants, the water intake, the urine output. Interestingly, urine output exceeded the water intake because of this obligate water loss. Is that what basically showed is that the majority of this water that's lost from infants in the first few days of life is extracellular water. So the postnatal weight loss that we strive to see in this population of infants primarily comes from contraction of the extracellular space, and remembering that the extracellular space has roughly about 140 milliequivalents per liter or millimoles per liter of sodium, is that there's an anticipated and obligate sodium loss that's needed to go along with this contraction of the extracellular space. When talking about how much water to provide these infants, we really have very little data to go on. And I put this up here just for comparison, is that, studies of antenatal steroids, we've enrolled almost 12,000 infants. The adults looking at beta blockers for hypertension have looked at 80,000 patients. And really there's about 5, what I could find is 5 really randomized clinical trials about how much water to provide early in life. We haven't even studied 1,000 patients. So we really have very little good prospective data to go on. This is probably the most well-known study by Dr. Bell, published in 1980, is they randomized infants to a higher low maintenance fluid therapy beginning on day of life 3 and continued that through the first month of life. They very carefully constructed their limits about how much fluid to provide them and took into account the urine volume necessary to excrete a solute load, allowing for a urine osmolality of 200 to 250, accounted for water losses in the stool, insensible water loss, including what would happen for phototherapy, and then water for growth. And they designed the study for at least a 20 mLs per kilogram difference between groups, with the primary study endpoint being PDA with congestive heart failure. And as you can see from figure over on the right, the table, these infants are obviously much older than what we're talking about, but these are the data that we have to look at. Fairly large differences in fluid intake, and again, this is the averages over the month. And maybe at the end of this, during our discussion period, Ed could talk about why these differences occurred. Percent weight loss, both really within the target area of percent weight loss that we think about, although the low volume group had a greater percent weight loss. And then you can see what the primary outcome is. Certainly there was differences in PDA with congestive heart failure, also significant differences between the rates of PDA and necrotizing enterocolitis. So although the study doesn't tell us how much water to be giving babies, it gives us the message that too much water is bad. There's been a few other studies that I want to touch upon quickly. This study by Lorenz looked at 88 babies. They looked at two different fluid regimens, although both of them were rather restricted. And still, by both groups targeted fairly significant weight loss. So their high fluid group actually targeted about a 10% weight loss. Their low fluid group, about a 15% weight loss. You can see on this slide kind of where they started and how they advanced over time. What they basically found is that, you know, the high fluid group didn't lose quite as much. Fluid intakes was vastly different, and essentially what happened is you gave more fluid, these infants produced more urine output, and so the difference in fluid intake was much greater than the difference in fluid output, because the kidneys were able to compensate for this additional fluid. Their bottom line was basically they didn't see any differences between these groups. Again, we were talking about fairly restricted fluid volumes in both these groups. And my take from this is that there's a range of acceptable fluid intake early in life, so long as we're allowing for the weight loss. And at the bottom of the slide, another study by Cavadia that was published in two separate manuscripts that essentially gives you the same lessons. A couple of significant retrospective studies by Billow and Wadhawan published in the early 2000s, several thousand babies. Basically, they showed that a higher fluid intake, which they defined as really a lack of weight loss from birth, was associated with increased risk for death or BPD. So again, not telling us how much fluid to give, but telling us that we really should be targeting for some degree of postnatal weight loss after birth. And recently, there's really been a plethora of publications. These are all since 2001 that have all looked at fluid balance in this idea that outcomes are optimized if we see a decrease in weight following birth. And most of these are targeting probably between about 5 and 15%. Again, we don't have a great targets yet. So we're going to move on to sodium. Again, very few studies that tell us what we should be doing with sodium. This is a study that didn't even include 20 infants. Sodium intake was restricted over the first 5 days of life, or given approximately 4 to 5 milliequivalents or millimoles per kilogram per day. You can see that urine sodium outputs were identical, but the bottom figure shows that there is clearly a difference in sodium balance, in that those infants that had the restricted sodium intake had a negative sodium balance, whereas those that were provided sodium were basically net zero. Again, small sample size to make conclusions about outcomes, but again, those with sodium restriction had decreased incidence of BPD. And then one other study that was looking at restricting sodium intake, either starting 4 millimoles beginning on day of life 2, or withholding sodium until a weight loss of about 6% of birth weight was achieved. So basically several days after birth. Fluid intakes were identical. Again, you can see that the sodium balance was more negative in those infants with whom sodium was restricted. And you can see here that the changes, again, in total body water. And the message here to me is that by providing sodium early in life, like I said, within the first day or two, is we're actually inhibiting that contraction of the extracellular space, or allowing that loss of extracellular water that those other studies suggest result in better outcomes and less morbidity and mortality. And here with what they showed is that in terms of the duration of need for supplemental oxygen, is that birth weight and the study groups, meaning withholding sodium or not, were really the only significant factors that were associated with decreased duration of supplemental oxygen. So that's basically the story for early sodium. in my mind. And then the rest of this, I want to talk about what I think is really the importance of sodium is to optimize growth. So this is actually a study published in the 80s that was done in rats, in which rats were given a sodium deficient or a sodium supplemented diet beginning at weaning, and showed that those rats that were giving sodium supplemented had increased growth. And this growth was not just weight, but it was length. And they also had increased efficiency of weight gain. So weight gained per gram of food intake was significantly greater in those animals that were provided sodium supplements as opposed to a sodium deficient model. This group showed that total body water was actually similar between groups. Here's another study. This group had a 30-fold difference in sodium intakes for 5 weeks. You can see from body weight that those rats that were given the least amount of sodium grew the least. But importantly, and I think this is really what the message here in terms of our concerns about giving too much sodium, is total body water in these animals was identical in terms of percent of total weight, despite the fact that there is a 30-fold difference in sodium intakes. Additionally, serum sodium values were identical. So again, and this tells us that we shouldn't be using serum sodium as necessarily as identifiers of those infants who are sodium depleted, as clearly in this study, the rats that were receiving the extremely low doses of sodium were total body sodium deficient. We published a study a number of years ago where we basically took data from the literature and estimated what we thought the urine sodium concentrations would be in infants over a range of gestational ages as well as postnatal ages, and then calculated how much total sodium they would be losing from their urine. And so if you look at the figure on the bottom of this screen, is that you can see for infants ranging from 23 to 27 to 28 weeks, is over the first few weeks of life, essentially all these infants are losing at a minimum 5 milliequivalents per kilogram per day of sodium from their urine. And a large number of these infants are probably not receiving that amount of sodium in their diet. And this doesn't even account for the sodium that you need for growth and to be in a positive sodium balance. Here's some more recent data where we looked at sodium homeostasis in infants 22 and 23 weeks. This was just observational data. Nothing within this study prescribed the sodium intake, but we started measurements at 2 weeks of life in infants 22 and 23 weeks. So each of these points is 2 weeks away from each other. You can see that the sodium intakes ranged up to about 8 milliequivalents. This is studies that were done in Iowa. You can see how high these urine sodium values were over the first month and a half to 2 months of life. And then when we look at sodium balance, and this is just intake versus urine, not accounting for stool losses or any other losses, as you can see, we really didn't achieve a significant positive sodium balance until 35 weeks. And so we clearly were not driving this high sodium output by giving high intakes. We were basically trying to keep up, and the fact that the sodium balance barely achieved zero until 33 to 35 weeks would suggest to me is that even with that, we were falling a little bit behind. You can see at the bottom kind of the rates of hyponatremia in these groups. So about a third of these infants had some mild hypernatremia. A study that I found interesting, this is from Isman, published in 2016, where she randomized infants to receive 4 milliequivalents per kilogram per day of sodium supplementation above that normally in the diet or placebo, and kept them on for 4 weeks. It showed that those infants who received the intervention, the vast majority of those infants maintained their birth percentiles at 6 weeks, where very few, only about 10 to 15% of those in the placebo group actually maintained their birth percentiles. So suggesting that the sodium supplementation basically helped alleviate postnatal growth failure. One reason for that is that the low amount of sodium that's in human milk, and even in supplemented sodium. And this is a recent study by Perrin, who's looking at the sodium content of unfortified milk as well as human milk that's fortified with several different available fortifiers, including prolacta, is even with recommended amounts up to 24 calorie and assuming a feeding volume of 160 mLs per kilo, is very few of these infants even achieved 3 to 4 milliequivalents per kilogram per day of sodium just within their diet. And so one of the approaches we did, and this was again just evidence that supplemental sodium is a benefit, is at Iowa we started supplementing infants who had unexpectedly low urine sodium concentrations. So we would screen them, and this was done in infants 26 to 29 weeks. We started screening them at 2 weeks of age, screened them at 2, 4, 6, basically ended the study at 8. Any infant that had a urine sodium less than 40, we supplemented with 4 milliequivalents per kilogram per day of sodium. So this is the demographics, and we compared this. We just started this at the beginning of 2016 and just adapted it as a protocol in our nursery, and we compared it to a historic cohort. As you can see that 75% of these infants at some point in that study period had a urine sodium less than 40, which we indicated represented sodium deficiency, and the infants then received supplemental sodium. Sodium intakes at the top, you can see that they identical at 2 weeks, and then at 4 and 6 and 8 weeks. And the 2016 cohort had about 1.5 to 2 additional milliequivalents per kilogram per day. Caloric protein fluid intakes were identical. Urine outputs were identical. But what we identified is that at 8 weeks of age, so this is after 6 weeks of the sodium supplementation, is that we actually had improvement in the mean Z-score of weights in the supplemented group between the others. So not advocating that using urine sodium concentrations is necessarily the right way to do it, but just more evidence again that I think that a large number of these small infants are experiencing postnatal growth failure, and part of that postnatal growth failure is related to being total body sodium deficient. So key points that I want to make is, I think it's important to avoid excessive water intake. Johan will be talking a little bit more about that, but we really need to use all the available data that we have to really help to decide how much volume to prescribe. We need to target decreases in weight for the first 45 days of life, avoid sodium intake as best as possible for about the first couple days, recognize there's a need for adequate sodium intake for growth, and that sodium isn't promoting growth, but sodium deficiency is impairing growth. So I will stop sharing and let Johan continue with this.
Thank you, Jeff, and thank you, Noel, for the opportunity to speak. I'll see if I can share my screen. Does it look all right?
Yes.
Yes.
All right. So I'll try and pick up where Jeff left, and so these are my main objectives with this brief talk. I just want to highlight some aspects of skin barrier function and loss of fluid through the skin in this particular range of gestational age. And to summarize the routes and a little bit of the magnitude of water loss and what you might expect in terms of postnatal trajectories regarding body weight and plasma sodium. Maybe give an idea of like crude estimates of starting fluid ranges, which you will see can vary a lot. And then just some small suggestions for how to look at fluid balance monitoring and maybe some targets that you could look for when managing these babies. And I want to stress the important fact that there is almost no data available in this group of infants. So bear with me regarding that. So firstly, about the immature skin, you all know the main functions of the skin. It's to serve as a barrier to the environment, and in this, relevant to this talk, is actually the function of the skin to limit evaporation from the skin surface, what we would call transepidermal water loss, or TEWL. And importantly, this function of the skin depends solely on the integrity of the outermost layer of the skin. And as this is the time period in fetal life when keratinization takes place, this is a very important factor in these babies. So if we look at micrographs from skin samples taken at 21 to 22 weeks and comparing them to skin samples from just a couple of weeks later, it's very evident that the red stain is staining keratin in stratum corneum is almost fully deficient at 21 weeks and reasonably, and we have a reasonably good cover a few weeks later. And this, of course, translates to the very well demonstrated inverse relationship between gestational age at birth and transepidermal water loss. So if you trust me, it's true that TEWL will only be of clinical significance in the tiniest group of babies. Let's say babies below 27, 28 weeks, while the skin of more mature babies are actually have a quite good skin barrier function. So what else except gestational age would influence on TEWL? We know that after birth, there's a rapid postnatal maturation. And so already after a week or so, TEWL will be reduced by, let's say, 50% in this population. We also know, and it's from the law of physics, that evaporation from any fluid surface will be related to actually ambient vapor pressure, but we mostly use ambient relative humidity as a proxy for this. And since ambient relative humidity and TEWL is mostly relevant in the tiniest babies, this is also the ones that might benefit or have an impact on their loss of fluid from being cared in humidified incubators. Has also been shown both in experimental studies and in one or two publications from measurements in infants that the insensible water loss is lower through the skin in babies that were exposed to antenatal steroids. In fact, TEWL is actually the signal for the epidermis to proliferate. And this has been shown in numerous studies on skin explants, skin cultures, and in animal studies. And we've also been able to demonstrate a slight effect on barrier maturation from high environmental relative humidities. So a high relative humidity in the care environment will reduce TEWL, but to some extent at least also delay the recovery or the maturation of the skin barrier. So one could say that high relative humidity will reduce TEWL and simplify fluid management to some extent, but it might not be a very good idea to use it for a long time. So if we look at the limited data available for TEWL in this particular population, we've demonstrated that the TEWL at 22 and 23 weeks versus babies born at 24 and 25 are clearly higher. And using these values to calculate total insensible water loss in babies less than or equal to 23 weeks, we see how much of a difference it would be if such a baby would be cared in a closed humidified incubator, solid line, as compared to in a drier environment under a radiant warmer. So insensible water loss through the skin would be in the 70-80s range on the first day of life if you're in an incubator, while it would be in the 200s if you're under a radiant warmer. So moving to just some data about what is available in terms of what do we know about what to expect in terms of postnatal trajectories of urine output, insensible water loss, body weight, and sodium. Dr. Segar has reviewed all this, so I'll just go to the second part, stating that respiratory water loss is negligible with humidified respiratory support. Stool loss of water in this population, at least early on, is very small. And since sweat glands are non-functional, we are only dealing, when we're looking at loss of fluid, we're only dealing with urine and loss of fluid through the skin. And we know from a couple of studies where urine output has been measured in this population that urine volume per kilo per day is around 100. And it's pretty stable, but maybe a little bit less after a few days. Moving to insensible water loss, we have demonstrated calculations from loss of fluid, total fluid intake, and urinary output. And there's an excellent Japanese publication on the same subject in this population. And we come up with approximately the same numbers. So insensible water loss through the skin in babies cared at high humidity will be in the range of 60, 70, 80 mils per kilo per day. And they will be significantly reduced after a week in the same, according to the pattern that we have also seen in direct measurements of TWL. So that would give us, at least according to the data that has been published, and they include some of them very few babies in the less than or equal to 23 weeks gestation population, but seems as if most babies will, in this population, in centers that care for them in a structured manner, will lose something in the range of 10 to 15% body weight. And day of life 4, 5, 6 will be the lowest point. And I would rather say that from the data published, it's more towards 15 than it would be towards 10%. And we know by experience that we have seen a number of babies that would lose 15 or even 20% body weight and without overt signs of dehydration. What also follows from this fact is that if you are at -15, let's say at day 5 or 6, it's not possible and it's definitely not desirable to return to birth weight within a week or even 10 days. There's scarce data also about plasma sodium in this particular population, but it seems to be so that the babies on average cared for under the circumstances and demonstrating the weight loss that I presented will have a peak of something in the range of 140 to 145. And the peak in sodium coincides with the lowest body weight. So how do you then go about to follow these babies? Well, if you first of all want to decide starting fluid volume, there are two important factors that you need to consider. The first one is, how do you care for the baby? So are you using a radiant warmer? Humidities in the winter time in the north could be in single digits, or are you using a highly humidified incubator with humidity in the range of 80 plus or 90%? And there's no data to support that any mode is superior to the other, but it's very clear that you must know the care environment because it can have a huge impact on the insensible water loss and thus on the TFI or total fluid intake that will be required. So it's highly advisable to choose one approach and then apply it uniformly in your unit. And the second factor, I think Dr. Bell will talk a little bit about this later on, is whether you're using prophylactic or early indomethacin. The studies that I presented previously with fluid intakes and urine output, those were from populations that were not exposed to indomethacin. And the exact impact of indomethacin on urine output in this population is actually not known, but it's probably considerable. So the advice would be to establish an interval for starting fluids for your unit and for the type of how you have arranged care, whether you're using radiant warmers or highly humidified incubators. So we have suggested that for incubator care, initial fluid volumes would be in the range of 100 to 170, while they will be almost another 100 ml for babies nursed under the warmer. For what's it worth, this is our protocol. I'm not saying you should adopt this, but this has been shown to work well in our experience with the particular type of care, the type of fluids that we use, and the care environment and so forth. So we have approximately 10 mLs difference in starting fluids from 22 to 23 to 24 weeks. And then you should have a target for weight loss and plasma sodium or serum sodium values. And I think it's reasonable to say that you should expect babies to lose 10 to 15% or a little bit more, and to reach their lowest weight at day of life 4, 5, or 6. And a reasonable target for plasma sodium would be less than 150 millimolar. Jeff alluded to this, so I won't talk about it anymore. And he showed you several more publications where they have, I think, clearly demonstrated that fluid overload is not a good thing. There is a range of fluid intake that the baby can compensate for or increase their urine output. But if you exceed this, you may run into trouble. And I think at least from the data that we have and our experience, reasonable targets is to aim for slow weight gain. Rapid weight gain is not growth, and I think that's important to stress. And at least in our hands, we have targets of less 10% below body weight at approximately 1 week, and another target would be at body weight or maybe a few percent over body weight at 2 weeks. Fluid balance monitoring will then include weighing the babies regularly. We weigh babies twice daily, first days until we think fluid balance is okay. It will require a scale built in the bed or in the incubator, but we think it works well and gives us valuable information. And in combination with following urine output and calculating balance and the checking of electrolytes, we think we can, since we know sort of what to expect, we can plot the baby in comparison with what we know and what we think babies do well with. And such a system is much easier if you standardize everything, or at least as much as you can. Things like care environment, meaning incubator humidification, some starting fluid, how much you should feed, give as little sodium as possible, and when you should start supplementation, and how you should monitor. And we found it helpful to use 2 separate infusions. So looking at nutritional supply is one thing that we sort of replace fetal nutrition, and the other one would be a low sodium content solution where we can adjust for extra water. Thank you.
All right, thank you for those excellent presentations. So I think we'd like to turn over to the discussion portion, and I'd like to hear from our moderators. So I think one thing that we could specifically go back to, in addition just to your overall kind of impressions, is the issue that was brought up of high fluid intake and the PDA and pulmonary edema. So we've received multiple questions on this topic from attendees, and so if our moderators could maybe specifically comment on that question. Maybe we could start with Dr. Bell.
Thank you for this question. I think it's important to point out that the risk of patent ductus arteriosus is not linked specifically to high fluid intake per se, but rather to the excess of intake over requirement. So if a baby's fluid requirement is 180 ml per kilogram per day, and you're giving him 180, that's not going to increase his risk of PDA. But if his requirement is 120 and you're giving him 150, that may increase his risk of PDA. So don't be stuck on the absolute number of ml per kilogram per day, but rather look at the relationship between what your estimated requirement is and what you're actually giving him. And I think that that was what we tried to do with that old study that Jeff alluded to back in 1980. Could I just take a moment to show a couple of slides that relate to this? Here are 3 centers with good survival at 22 weeks gestation with very different starting fluids. At the University of Iowa, we start 22-weekers with 180 to 200 ml per kilogram per day. At the University of Uppsala, as Johan said, they start with 120 ml per kilogram per day. And at the University of Cologne, they start with 70 ml per kilogram per day. But all 3 of these centers have greater than 50% survival at 22 weeks gestation. I want to credit Matt Rishavi, who put these slides together. And how do we explain this? Here you can see at the University of Iowa, we use radiant warmers, and we have a low relative humidity. It varies with the time of year, but it's roughly about 40% most of the time. So we have a large intensive water loss. And so we have to provide a large intake to replace that large insensible water loss. But the important thing is that we have the intake is designed to match the sum of the outputs of insensible and urine, as Johan mentioned. The other outputs are not significant in this population. If we move to Uppsala, the babies are kept in incubators with high relative humidity in the first week, and so the insensible water loss is much less. And so the amount of intake that's required to offset the insensible and urine losses is much lower. It's about 120. And if we move to Cologne, where the relative humidity is high, but babies also receive early indomethacin, they have lower insensible losses, but also lower urine outputs. And so the amount of intake that's required to offset these outputs is even lower. So the important thing is that these intakes are designed to balance the outputs of insensible and urine outputs.
Great, thank you for sharing that. Yeah, another question that came up quite a bit was about the frequency of hyperglycemia in this population that can cause, osmotic diuresis and other challenges. So I wonder about your thoughts on kind of the frequency, how to prevent and treat hyperglycemia in this population. And maybe we could go to Dr. Kasuda now. Dr. Kasuda, can you hear? I think you're muted.
Oh, okay, sorry.
There you go.
Sorry. Okay, yeah. So before talking about hyperglycemia, can I comment about the fluid intake?
Of course, yes.
Actually, Japanese practice is maybe between somewhere between Uppsala and Cologne. We start probably around 100 ml per kilo per day. And we believe this is not fluid restriction. As Johan already showed, the environmental humidity can make the huge difference of insensible water loss. And we prefer high humidity. So we do not restrict the water intake. It's just the result of environment. If we use high humidity, we don't need much intravenous fluid. So that's why we just follow the urine output and also body weight and also sodium concentration. And also we always evaluate the echograph, ultrasound measurement. So we need maybe personalize the fluid intake. And once we adjust the appropriate fluid intake, maybe actually it's a result of the infant actually requirement. So we should start at a certain level, but we should adjust. We need fine adjustment, maybe every 12 hours or every 6 hours. So I think it's a good way to adjust the water intake and sodium concentration. And then talking about hyperglycemia, yes, we can see any high incidence of hyperglycemia, but we usually allow to up to 200 milligram per day. I cannot convert to the ml, but at around 200 milligram per dl, we allow to that kind of hyperglycemia. If it exceeded, sometimes we use insulin, but we try to avoid the use of insulin. That's my comment.
Yeah, we have a couple of comments in the chat, which are, I think, very relevant. And I think one of them is about using two separate infusions. I think as Dr. Johan Agren mentioned about using one for nutrition and one for fluid and electrolytes. So what fluids do you advise using for the fluid and electrolytes? They use something like 5% dextrose or even lower. I know some people use something like 2.5% dextrose.
Yes, thank you. Yeah, we use 2.5 dextrose. And it's just the idea that we would not want to turn the knob up and down on a TPN bag. So we find it better to keep that infusion rate constant, and then if someone wants to give more water, it's easy and has less impact on glucose, obviously.
There's another question about how do you manage the use of sodium when there is often a possibility of metabolic acidosis and the need for sodium acetate. So do you restrict sodium except for the acetate, or do you also restrict the use of sodium acetate?
We try and restrict all sodium. So I'm fully aware of sodium acetate probably being a more clever idea. We use sodium chloride in most cases. So, and it's we're not so worried about slight metabolic acidosis.
Great. Yeah. In the submitted questions, we have had some questions about enteral fluids and about when do you start feeds, and do you count that as part of your fluid intake, and do you use something like free water drips for fluid management?
Right. So that's a very good question, and I think it obviously also impacts on fluid requirements. I mean, everyone knows it's not the same to give an IV than to feed something, but we are quite active in feeding. So we start all babies this gestation at 1 ml every other hour, so 1 ml Q12. And then we increase it. So next day is 2 ml, 3 ml, 4 ml, and so forth. And we include that in the TFIs. So
excellent. Yeah.
Yeah. And the other question was that was water drip or water feeds. We did that in the 90s, and then we realized that we can give breast milk instead. It doesn't have a whole lot of sodium, so we thought better to keep nutrition going. But I also must emphasize that this is only our practice, and no one knows. There are no studies in this area, and it's we tend to rely on physiology, but there's probably many situations where we could go wrong. We think this is a good idea, but it might not at all be true, and this population might be very different from babies at 28 weeks or so.
Oh, definitely, yes. Yeah. And there have been many questions in the submitted questions about management of hypernatremia and hyponatremia. So maybe our panelists could discuss briefly on how they would approach it. I mean, obviously, it's better to prevent it, but suppose you have an infant with, say, a sodium of 155 or maybe even 125. How do you go about managing them? Well, I think, first of all, is need to understand it at one point are you talking about the hypernatremia. If you're talking about the first couple days of life, you know, that would suggest that it's an infant that has a free water deficit, and that needs more water. And you know, we would take the approach that Johan does in terms of using D2.5 to essentially provide water without having a significant impact on you know, serum glucose values. And you know, and it goes back to what Johan says about the importance of you know, you need to assess these babies. You can't check a serum sodium every 12 hours on these babies, because things, particularly given the amount of insensible water loss that these infants have, is that their serum sodium values can change relatively quickly, and that you need to always be anticipating what these changes could be, and start looking at trends in differences in serum sodium or serum chlorides early, and not wait until you have a sodium of 150 or 155. And conversely, if you know, within the first couple of days we're talking about hyponatremia, that suggests that you've been giving too much free water and that you need to cut back on the amount of water intake.
I think the problems that are described with hyperglycemia and hyponatremia, or excuse me, hypernatremia, may arise from increasing the IV rate without changing the composition of the fluids. If your baby starts to lose weight too fast and you're concerned about dehydration, the baby needs more water and not more of everything.
There have been many questions also on the frequency of monitoring, not just weight, but also electrolytes and urine output, and perhaps urine specific gravity. So how frequently do you all measure those?
We monitor electrolytes very often. Specific gravity is not terribly helpful, urine specific gravity, because the baby's renal immaturity makes that not particularly useful. But weight, I think once or twice a day, but we monitor electrolytes sometimes every 3 to 4 hours in the early days.
Yeah.
We have a micro lab right in the NICU, which makes it very easy to do those things.
Yeah, also in Japan, we can measure the sodium concentration by using the blood gas analyzer.
Yeah.
So anytime we take blood gas, we always check the sodium concentration. And also, as Ed said, we rely on the ultrasound measurements. It's not invasive test, so we rely on the frequent echocardiogram.
Okay, Noel, I see we just have a minute or so left. Do you have any closing comments or any final questions?
No, I just would like to take a minute to just thank our speakers and our moderators, and for everyone who attended. We'll reach out again with information about our next webinar, and we hope that everyone can attend.
Thank you. This was an excellent show. Thank you all.
Thank you.
Thank you.